And Samir Mehta.
Okay, they want to go to room 1 first. Sharma wants to show his handiwork. Quick.
Okay, Dr. Sharma, show us what you did.
Yeah. No, where is Moreno? Moreno should be there also now, right?
Not here yet.
No, he should be moderating.
He's not here yet, sir.
Okay.
He's stuck in a case.
Okay, just 1 second. So let's just show, because this is the tough case of the day.
Yeah.
So you'll show them 1 second. Okay. Yeah. Okay, now we left you at this place. Yeah, I know that they're ready for this. This is already done. Multiple issues that we are able to finally get the wire. The guideliner, as you can see here, require a lot of manipulation, fine cross. Then lesion here, very complex lesion. We put a rotawire, then brought the burr out. The rotawire got the bent. So we were able to, with the guideliner, balloon dilatation, the stent. There is a stent in the mid, a stent in the distal, but the guideliner has been our friend. This is the only way we could do this case so far. And this is where we are. And knowing that this patient can come back for the future restenosis, it's a beautiful result so far. We said, let's open the osteal RCA with the osteal flash balloon.
Nice.
So that's where we are now.
How did you get, which guide, the most important thing was,
guide is the
what
same.
was the problem with the guide?
My initial guide, which was prediction for the case, was the no torque guide.
No torque guide.
3D RC is the same, 3D RC and no torque. That is basically went, whether let's see if this goes in. If not, then we just stop it here. We don't have to get crazy. It went in.
Incredible.
Yeah. So this is now the osteal, So it's still very difficult. Yeah, good.
Oh, good. You got it.
Yeah.
It's not quite.
Yeah. But as long as we can open it here.
Just to open a little bit, right? And the osteum.
Yeah, go. Yeah. That's good. Good?
No, it's not going to flash. The balloon is too far.
Okay, negative. Yeah, just 1 second. We're trying to jiggle a little more. If we can get the guide in a little more. No, before that, you have to bring the guide on the balloon. Yeah, this is the osteal flash, and if they have the animation, they should show the animation.
Yeah, the osteal flash has it's an important design. There are two balloons, two separate. One is what you just saw dilated,
and we'll show that now as a double balloon. Okay, ready? So purpose is that osteal that we just open.
Yeah, there you go. You see that? And that's to really trumpet the osteum.
If we have to come, we'll be able to come very easy. Hopefully things will be easier. Or maybe never needed, but will be easier.
Yeah, it was amazing. I mean, we really didn't know.
After the initial dilatation, we were able to get the stent. It was a 3.5, 28 Zions, and the 3.25, 28, and 3.25, 8 millimeter, because the distal lesion was a little more apparent after that.
That's amazing. Incredible work. I mean, we really were like, how is he going to get this done? But you did, of course. There's never a no for Dr. Sharma. A beautiful result. Thank you. Excellent. So are you going to, what's the plan for this patient next?
Actually, if you want, just. So that's fine. Yeah, no, you have to. Yeah. Okay, so we just show the last picture and then you go to room 6.
Yeah, no, that's beautiful. And the panel is complete here. And once Dr. Moreno gets here, I'm happy to hand him the microphone. But I was called that he's stuck in a case, Dr. Sharma, in Uptown. So he'll be down soon, hopefully.
Okay, this was a marathon case, but came out very, very good.
Beautiful.
All right, you go to room 6
case.
now.
That's great. Okay, Dr. Kinney, case number 8.
Case number 8, we have a TAVR of a 79-year-old male who has a history of exertional dyspnea, but if you see patient has paroxysmal AFib on hemodialysis, COPD, history of peripheral vascular disease, and in the past what he did have multiple PCIs, but also a BAV when he was pre-op for a AV fistula. So that was way back in December. Since then, now he's symptomatic, so he's back here for TAVR So we're going, as you see there, we're going to show you the echo quickly and then the CT scan. Next slide. This is the echo which confirms that patient has a significant aortic stenosis. Show the CT scan. Next.
Wow.
Good afternoon. So you can see there's a lot of calcium in the aorta, ascending arch. The annular plane is fairly vertical, so not challenging at all in terms of horizontal aorta. Next slide. Next. You can see here's our annulus. The annulus itself has a few spicules of calcium there at about 12 o'clock and 6 p.m., but nowhere near like the calcium we had in the last patient. Area is 5.4, which puts it in the range for a 26 Sapien S3 valve. Next slide. You can see here the LVOT, are reasonably generous at around 5.8 centimetres. Next. Sinus of Valsalva, again, generous, not a problem, around 30 to 32. Next. Coronary heights, the left is about 13, right about 12, so not a concern here for the coronary heights.
So you, JK, what is the coronary height that you think we should be concerned? Tell us about that.
We usually get worried at around, it's a combination of multiple factors, including the coronary height, the length of the left leaflet of the aortic valve, and also the width of the sinus of Valsalva. But less than 12 is where we're getting concerned. This is a left main of about 13 millimetres with reasonably generous sinuses of Valsalva, so it shouldn't be a problem or a concern for left main coronary occlusion.
So that's where we are. If you have a low height and you have a small sinus of Valsalva and your leaflet is probably long, that's when you think that could be obstruction of the left main.
Agreed.
Yeah,
absolutely.
But you don't have to worry.
Waxman?
No, I just have one question. Do you have any surgeon in the room right now, or cardiothoracic surgeon?
Alan Stewart.
Alan Stewart's right here.
Alan Stewart is our cardiothoracic surgeon.
So you keep a surgeon in the room?
Always, always, in every case.
And is there any reason why you choose one valve versus the other in this case, or you just want to even out because we saw before Evolut Pro and now we want to see something else?
No, I think this very good point. There's obviously some patients who are better suited to one or the other. I think this is an anatomy that could have happily gone in either direction with either valve.
Yeah, I think a more important point which Ron Waxman pointed. If we have this kind of borderline left main cases, we definitely, if the vasculature is suitable. I think I would say two things. The vasculature has to be suitable since the sheath size is still bigger for Sapien compared to the Evolute, not Pro, the regular Evolute. Evolute Pro has gone back to 18, otherwise just Evolute would be 14 French sheath. Other than that, if you have a low coronary height and we think there will be likely obstruction of coronaries and we have to protect it with a guide and a stent in the vessel, that's the time you would go for Sapien versus otherwise Evolute. Yeah, and the valve in valve, I think we will favor more of Evolute.
The data is clear for Evolute in that situation.
So a patient like this, you're going to show us what you do. We're going to watch you. More importantly is that this is an end-stage renal disease patient on hemodialysis and also atrial fibrillation. Will you send this patient home on warfarin or on a novel or oral anticoagulant, and for how long, and what do you do there? How do you balance the bleeding and everything else?
Now, patient has already been on Coumadin, in which case we will just continue on Coumadin. Otherwise, of course, we have your trial going on where we are randomizing patients to Novak versus aspirin Plavix.
Yeah, okay.
The next slide.
Yeah,
great.
Next slide. You can see the access. The patient does have PVD and has had previous PTAs before, but the access is reasonable. We've gone up the right side with the main sheath. Next slide. Next slide. Here you can see fairly straight. There's some spotty calcium, but nothing too problematic. Next slide. And here you can see the valve selection according to the size of the annulus and other considerations. It's a clear 26 millimetre S3 valve. Next slide. So the case, we've really already summarised it thus far, so I think we can just move right ahead.
Yeah. And one other thing that since we have the Sentinel approval, every case, especially this one, you saw the arch, a heavy calcium, lot of atheroma in the arch, that if suitable anatomy, especially your arch in the CT scan, we will be able to get the Sentinel device that we will be using Sentinel in many of these cases. Same thing, you don't cross the valve. We have the Sentinel here ready that we are going to go up with the radial. We went with a 300 Grand Slam.
So this is great. So you're going to do a neuroprotection here, is that
Yes,
correct?
Exactly.
So let's hear from the panel. The Sentinel device is a neuroprotective device, a double filter. Maybe our crew could put it up so people could see on one of the screens.
They should show in the factoids the Sentinel.
Yeah, they can show us that. Very important, it comes from the radial side. It's a dual filter, covers...
So if you see here, now I'm in the right brachiocephalic artery, and you can see the filter. You have two filters, one at the distal and one in the proximal.
That's right.
So the proximal is the one that will be deployed in the brachiocephalic. Do you see that? Let me go see
Yeah, we see it, and I'll show it.
Yes. So I'm just going to go way further down. Now you see the distal filter. So you need to give about a centimeter gap from the ostium of the origin of the brachiocephalic. Is right there. And it's all nicely marked, if you can show here.
It's very simple. As you're going to see very, very quickly, Dr. Kinney is going to put that filter up.
We go a bit further, see the pigtail of the aorta.
And if you're not sure, you have the pigtail there, you can take a picture. But I think this is very straightforward.
What's nice about it is that you actually don't need too much to give more extra dye. You'll see here. So
now I'm going to pull what they have marked number 1, which means the proximal filter is going to be deployed. If you can watch that.
Here goes the proximal filter.
Yeah, it's coming out.
Here it comes. You see that?
So after that, what you do is you hold your left hand right at the proximal filter, and then I'm going to pull back. If you see, is number 2 now. So now I'll be working on number 2. I will just pull this back. We have to rotate it. JK is pulling the wire back, the distal tip of the wire I'm pulling. And as I reach here, I'm going to rotate. So it will now face to the
common carotid.
Yeah, left carotid.
Carotid.
You'll see it.
You can
advance a little bit more.
Here you go, and you see how nice.
Rotating.
And now you'll go up into that.
Let's have echo up, please.
The T is
yeah,
in
if you take the
way.
T out of the way so we don't see it.
Yeah. Rotate a little bit more. Yeah.
And now she released the
Now
second
here
filter.
she is, and she's going to release that distal filter.
So now you went into the internal carotid. So we're just going to, the number 2 has done its job. You want to pull the pigtail down. Good. That's good, right?
And you see there's very little, and we're going to watch the interaction of the device to this.
We will advance the distal filter. You just see here, JK is holding the wire. I'm going to advance the filter here.
Here we go. And there goes that second filter.
And then you can pull back the wire a little bit, so you're not way deep in the internal carotid. It looks good, right?
Excellent.
Agree?
The whole system back a bit. Right?
So that just stays there, and it's really irrelevant, and hopefully with very little interaction with the devices as they come across the aorta.
Give us some wet towels.
In the Sentinel trial, there was a non-statistical significant, but a reduction in lesion volume in patients who had this. But in every case, there was collection of debris in the filter. So the device is now approved, and this is for these patients. And now you're going to go and do your job. You saw how simple that is. So let's go to the panel. What does the panel think about neuroprotection? Yeah, Deepak.
You know, I was just gonna, I mean, it was beautifully deployed, and it seems like it was done with no risk to the patient, so I can't criticize anything about the technical aspects. But as far as the data, you know, it was a negative trial, and even though intuitively it makes a lot of sense to do this, I always get a little nervous when a pivotal trial is negative, and we're using something that brings some complexity to the procedure, some risk, especially in hands that aren't so experienced.
If you can show the hemodynamics, so
it does make me nervous, the approval of the device.
Question, and we could kind of talk about this because it is. There's no question the trial was negative but there was a reduction, but it was negative. It didn't meet the statistical significance. Exactly correct. There was numeric reduction. It was an incredibly safe device, and a numerically reduction of stroke from 9 down to like 5% or, you know, it was a good reduction in the stroke patients, but again, not statistic, wasn't powered for stroke. What does this panel think about the neuroprotection during TAVR? Ron Waxman, let's start with you.
I'm very happy that it was approved. However, the utilization, I think, or broad utilization needs to be more based on more data and more studies. We did learn that the MRI, DW is not a very reliable endpoint. We'd like to see some more hard endpoints. We'd like to see probably more data to generalize it. But often we do have cases like this one or others that we see in atheroma in the arch, and we feel that we know that there are distal embolization there. So I think we'll have to start to select patients, although again, nothing from the study shows us who are at risk. So I think Deepak was right. It's a little bit uncomfortable when you don't have the data, it's just by intuition. It's good to have it approved, but I think it's upon the sponsor to continue to study and give us some
study more people, exactly.
Okay. Yeah, and Mike? Actually, I mean, I think the point remains that at least we have a device.
Oh, there you are.
May not to be used in everybody, but some cases. I mean, as I showed in the data also, that clearly the issue remains that once your primary trial is negative, how do you do? But I'm sure the FDA still took it very positively. And they got approval. So in some cases, so people ask how many cases. Actually, we just had one of the media person called us that how many cases you think you'll use it. From my point of view, I think until we know a little more, probably 20%. I don't know, Ran and Deepak, maybe the number will be what? But that's what I feel.
There is also a cost issue. I mean, so we cannot ignore that part when we're struggling on the margin of profitability of doing TAVR. But I want to ask you, why did you do BAV? The gradient didn't seem to be that high there and not severe calcification. So, and you yet elected to do
it. Is it because of high calcium? JK, what was the reason for BAV in this case?
So the patient had a BAV, but it was quite some time ago. That was done in preparation for the dialysis fistula. I agree there wasn't a lot of gradient, but the leaflets themselves had some calcium. So we generally tend to BAV our cases if there's, you know, some equipoise.
Okay.
Now I think there is more and more data that you can skip that step. I mean, it started with Eberhard, but I think also on S3. I mean, we doing it only when we have a high gradient or very calcified leaflets.
John,
well, I mean, after today's discussion, we'll start doing less BAVs now.
Yeah. So we're just going up. So you have the loader cap through the valve.
John LaSala has a point, Dr. Kinney.
Yeah, just a couple caveats too. Remember, these people are screened with their CT scan as to the appropriateness for the Sentinel device. So there's a lot of anatomies that are not as easy as this. They can be very challenging. I know on my anecdotal experience, it takes me sometimes as much as 25, 30 minutes to get it into position. Particularly tortuous calcified vessels coming through. Different types of aortic arches are more suitable than others. Some are completely excluded. So remember that these are screened ahead of time. And even though it's approved, and I agree with Ron, it's nice to have that approval, I'm not sure the general TAVR deployers are going to use this universally, and they might self-select certain high-risk populations for its application.
So now we are in the descending aorta. So what we are going to do is align the balloon and the valve. Just keep coming back. Keep coming back. Till you see that is a white marker. When you see the white marker, you stop, you lock it. Then you have the fine adjustment where you keep rotating counterclock till you get, and you see the tip of the balloon marker is just within
right inside of the valve.
You just unlock, lock.
Yeah, release the tension.
That's important. So at this time, the first operator will be advancing, and I'm just going to flex the wheel so the entire catheter bends. So we are going across the arch.
And see that it does not affect our Sentinel device.
Yeah, so that's important. So you want to watch the travel on the arch.
You watch that there's no interaction or pulling on that device. And you see how nice it just goes
completely flex.
And I think this is
one of the advantages of this device.
Or greater arch of the aorta is really has been the factor with all the S3 showing the CVA rate of 1% or low.
Again, so what you need to do is now you unlock here, pull the flex catheter back completely so that your balloon is exposed. So say you have 3 markers, you come and stay at the center mark there. Lock it again so everything stays.
And just come off.
Where is your pigtail?
Just stay off.
Yep.
Stay off.
Let's bring the pigtail.
Yeah, you have to bring it.
You haven't got the angle yet, okay?
You have
just stay off fluoro for a second because you have to put that. We're just finding back to our root angle for deployment, which is here. So it's LAO 10, no craning.
Give me the wire for the pigtail. Many times, you know, getting the pigtail will be very difficult here.
Okay, so we need to put a wire into the pigtail. And these patients with the peripheral disease, catheter gets so much kinked. So it's best is just put a wire back and as if you are advancing. Pull a little bit. No.
Get us a stiffer
It's a
wire.
stiff wire.
Sometimes
It's a
it's good to
sheath wire.
take the pigtail a little bit back to the descending and start to travel.
There you
Like
go.
now,
We did that,
beautiful.
There you go.
Good.
Counter it.
That's good enough.
There's a lot of tortuosity. We see
Go,
the
go.
catheter down below.
May I ask, do you routinely use TEE now on all your procedures?
No. Not in every case.
And not every case
I would say
is-
30% we will use
is some conscious
transthoracic
sedation.
in the sense same that you finish the echocardiographer is around, and at the end of the case they'll just quickly do a transthoracic echo and tell us everything looks good.
Yeah, we've moved to doing predominantly transthoracic
Exactly.
and not TEE now.
Okay.
Do cut down, conscious sedation, no TE, and I think soon you don't need anesthesia in every case because you can
Okay.
actually give them Versed and
So,
fentanyl like a
Very
regular
important
case.
is you go at 180 and check the valve position same. You have the annular plane and your balloon dot has to be just at that annular plane. 180, okay guys? Go 180 pacing.
You want to first see where you are?
Yeah, probably you want to
Yes.
give.
And reason for pacing is your blood pressure has to be less than 40. So I think it looks good.
Yeah,
Everybody agrees?
yep.
Okay,
Yeah.
we're going up now. Pace 180.
She checked the pacer before,
Yes.
Roxana.
Yeah,
Make sure it's
she
working.
checked it that it's working.
Now I know the blood pressure is 40. Slow.
It-
When we are halfway through, then you go full expansion.
Okay. You stop the pacing.
So one of the things that we're doing a step. So we inflate some, inject, and
Okay,
then
good.
if we
Stop
confirmed,
pacing.
then we go all the way.
And as coming out, you unflex it, leave it there. If echocardiographer is around, we quickly ask them if it looks good.
Yeah, actually, you know, your point that a lot of people do that inject while you are. I always felt that there multiple issues occurs then
Blood
at the
pressure.
time when you are deploying the valve and still giving the injection. So we will many times will pace, give the injection, make sure the valve does not move. If moves, then do it again. But at that time when deploying the valve, we're just not giving the dye at that time.
Is there AI on the? We see AI on the
No.
color. there
Dr.
on the-
Chaudhary looks good, right?
Yeah, we see mild paravalvular regurgitation.
Yeah. Mild is
So
okay.
even though this is not a self-expanding, sometimes it takes about 5 to 10 minutes and it's going away without any manipulation.
And also you have to, adjust your...
And take the wire out also
wire
because you have a
little bit.
wire there,
Right.
so
Yeah.
that's also can interfere.
Okay, ready for the blood
Part of that's
pressure is
related to
good
the
now.
seal.
Blood pressure is picking up. Your systolic is just about 80, diastolic about 50. Okay, inject.
No,
I think
it
this
looks
is a beautiful
good.
result.
Is it a central
good.
Yeah,
probably?
that's a central.
I would do it without the wire. The wire is can
Okay,
mislead.
we'll do it.
Take this.
If you need to cross, it's not a big deal to cross again.
Okay, do another aogram.
And I would wait about a minute before that, if you
Inject.
have time.
Oh,
They're still here in
that's
AR.
acceptable. So if you check the hemodynamics, same diastolic just about 80 now, right?
Yep.
We're done.
We don't, I'll fix it. The retrieval.
So now the last step remains the retrieval of this very, I would say really what a mastery in terms of making the sentinel device able to get two filters and with this and majority of the time it's successful. If you think about theory point of view, you will say, well,
Can you bring
if
the
you're not
PE up?
used it, that how difficult it will be. But it's as you saw earlier when Anu deployed it, it's really very easy to do. Once you have identified the correct
PE,
anatomy.
can you bring it up?
So once you have identified the correct anatomy,
Up.
that 90+% of cases you can deploy and
Can you
retrieve.
just talk through how you're retrieving this,
Okay,
please?
now what I did was, if you can show here, initially to deploy this number 3, I had pushed forward, which was a filter. So what I did is, you pull the number 3 back, so the filter is inside. Now that part is done, then you come to number 2. So in number 2, you undo the curve that we had.
It's going to go straight again.
Yeah.
There you go.
So that's good. Now you bring your handles together. Very, very important. They say the handles have to be together. Without these two handles being together, you cannot go to step number 1. So now step number 1 is same. I had pulled it back earlier. Now I'm going to go forward. So your filter is inside. So everything is locked inside now.
And let's see if there's anything in there. That's really what I want to see.
Yeah, microscopically knowing that 90+% of cases in the trial had some debris.
Well, let's see what you got in there.
Make sure you put some.
Maybe the microscopic debris.
Here. Show it to them.
Maybe we need an electron microscope.
Well, let's see. And your anticoagulation was just low-dose heparin here during the procedure. Is that correct?
No, but they cannot see it here.
No, I will. We will open it. Okay. They want to see us opening?
Yeah, they want to see. Advance it.
So, Roxana, you know the data very well. How much of this was macroscopic, or how much you need to see microscopic? Because
it was visually, it was like 90+%,
so it was
and
already
then 99.9%.
Yep, 90+% you see the visual debris.
Yeah. So we should.
No, I think it's all microscopic.
Microscopic. That's it.
No, it's Deepak speaking here. No, the case was masterfully done. There's no arguing with that. But I would just say, though, when we're talking about
there's got to be something.
We found something in the distal one. See that?
Yeah.
Probably a chunk of calcium from the previous.
A chunk of calcium.
Yeah,
right?
that's why we don't like to do pre-dilatation. Many of them just a big chunk of calcium.
Just hold it there.
But when we're talking about MRI findings like that, it seems like as a community of interventionalists, we hold data to different standards, because if you look at the carotid stenting and carotid endarterectomy literature, the filters capture a lot of debris with carotid stenting. Cross-clamping and doing endarterectomy captures almost all the debris, but yet we're concluding that carotid stenting is as good as carotid endarterectomy, despite the fact that carotid endarterectomy is much superior to carotid stenting if MRI-defined lesions that are asymptomatic are the endpoint. So, I'm still not convinced that the MRI findings necessarily translate to clinical events. Having said that, I'd rather not have abnormal MRIs.
I think what we just saw, though, Deepak, you see that chunk of calcium that is now retrieved. Now, maybe it wouldn't have gone up north, I don't know, but that's pretty impressive. They just showed it.
In the distal filter. But while we are continuing discussion, I think we let Anu go. We are ready for another case with the CDO.
This was a conscious sedation. We have Minakam, who is our anesthesiologist, who has done a tremendous job in this case. And this was a PERC case, which they will do post-closure with the PERC close. And this is a patient could go either CCU, or I think if everything looks okay, is likely could even go to the floor.
No, telemetry floor, yes. We have the separate step-down unit for these intermediate risk patients, and they, basically has worked out very well. Even the staff has been trained to take care of the temporary pacemaker, because that was one of the biggest issue was, because many of the unprotected left main after Impella, everything looks good. Because CCU is always full, we send them to the telemetry floor. So they were very well adapted to take care of complex cases. Issue was only the management of the temporary pacemaker. But with the education, we are able to send even patient with a temporary pacemaker to our telemetry floor.
Wonderful.
Yes.
Really, really good. I mean, I think that, when we see that debris, it is compelling, I would say.
I agree with you. It is visually compelling. I feel the same way.
I don't know what it means.
But I felt the same way about thrombus aspiration and STEMI. In fact, I used to do thrombus aspiration in high-risk end-STEMI.
And every time you get the material.
Yeah, and I felt good about it. I actually published that end-STEMI thrombus aspiration and circ as a series of images. You can get a lot of thrombus, and it intuitively in that setting feels like it should have worked, but then the large outcome trials didn't confirm that.
So Deepak, one of the arguments is that we don't check thoroughly the patients from the neurological perspective. There are a lot of cognitive changes that we say, okay, the patient was like that before. Maybe this is actually more than what we believe, but I agree that we need more data to see where this should fit.
No, I agree with you. Looking at cognitive function closely before and after would make sense. And if that were favorably influenced, that would be a strong argument.
It's just that it's so hard doing. We did so much work to get cognitive function And these neurocog batteries of tests are so impossible to do in these elderly patients. Extremely difficult to perform and difficult to. So I think the best is to do the hard endpoint of stroke, and hopefully somebody will do this. Mike?
I think this actually thrombectomy is a very good comparator. I think the problem with the trials was it was always all or nothing, right? Everyone should get thrombectomy, or now no one should get thrombectomy. Yeah. When actually, I think clearly I pick and choose patients with very high thrombus burden. I use it, otherwise I don't. In this case, I think I would have used the Sentinel device because you do have some predictors of clearly some predictors of stroke from the CT scan. I wouldn't use it in probably the majority of patients, but I think it clearly makes sense in that sense to pick and choose based on your common sense.
Yeah, that's an interesting comment.
Don't worry about it.
Anybody else have anything else to add? Dr. Sharma and Dr. Kinney, are we going? What are we doing now? Jason, are you going to show us closure?
I think you're meant to be going to another room. I'm happy to talk you through the closure if everyone wants, but I think you should be going to another room.
Oh, it looks like we're going to room number 9. Yeah, here we go. Case number 9. Hello, Dr. Kinney, in another room. Hello.
Oh, so case number 9 is LC, 81-year-old male, who actually had presented with exertional dyspnea and had a positive stress test. Now, along with the stress test, when he had an echocardiogram, he is another patient who also had a low EF with 25%. You see, he was on good medical therapy, and cath was done sometime in May, which showed that he had LAD, actually LAD CTO, OM CTO, and RCA disease. So, syntax of 33. So he was taken out of the room. He did meet the surgeon, and subsequently surgeons always ask that when you have low EF, totally occluded vessel, that before they open up, is there ischemia viability, which was done for their sake, and then all the territories were viable, and then subsequent meeting he still refused CABG. So here he is for PCI. Initially we were thinking that we should do the RCA PCI followed by...
Can you show us some of the angiograms so we could see?
You can see now, this is the LV gram. What is the EDP?
Wow.
25.
Yeah, and EF, this is the EF with the EDP of 25. That's right.
And you have viable myocardium somewhere?
Everywhere.
In the CTO and everywhere.
Play next. Go next.
No, where's the right? That's all you did?
Yeah.
Okay, this is the right coronary artery, which you see about a moderate, I would say 60-70% disease in the prox to mid. And the angiogram that was done before, if you see there,
yes.
Mid, which is a heavy calcium, but I would say what that connecting that is all bridge collateral.
Uh-huh.
And then you have there's an OM that is totally occluded, which you don't have a picture, right?
We have one.
Okay, here.
So
that led to another totally occluded obtuse marginal.
Right. Oh boy. Okay. And the patient, obviously with the EF like that, the surgeons are not taking the patient, or?
Yeah, surgeons said, no, I think after the discussion with the surgeon, once they give them whatever the risk that they give, he definitely refused.
Oh, the patient refused.
Patient refused, yeah. So here we are for the PCI of the CTO of the LAD.
Okay, so we have severe 3-vessel, 2 CTOs, even the right coronary in that proximal area looks like there's some lesion there as well. We can talk about any comments about the current strategy, going after the LAD. It looks like she's going to go antegrade. We're going to talk about antegrade versus retrograde. I think you always start antegrade, is that right?
Yeah, always start antegrade, first attempt, second attempt. In very rare cases where you think there is ostial occlusion, there is ostial right, ostial LAD, and you have good collaterals, then primarily you want to do retrograde.
Okay, so we have a great panel here. Why don't we start with John LaSala? What would be your strategy? You like the Impella?
Let's get the Impella off there.
Well, it's a low enough ejection fraction, so you'd be concerned about it. Impella for CTO is probably more important if you're going retrograde, because if you're cutting off some of the collaterals, you have a higher probability of a larger ischemic zone and more decompensation, but certainly reasonable in this situation. The nice thing about the CTO is you've got, it looks like a calcified tract there to follow, which in addition to your retrograde flow will hopefully direct your wire into the right spot. I mean, proximal cap is a little bit indistinct because it's coming off right at the diagonal. So that's one thing not in your favor, so you may be looking at a possible dissection re-entry.
Dissection re-entry. Dr. Bhatt?
I think this is a really logical approach. I mean, I would have pushed the patient towards surgery as much as possible because LV dysfunction, triple vessel disease, demonstrated viability. I mean, there's mortality benefit. But if the patient really was refusing, then I think the PCI makes sense. It's a support device. Probably fine for peri-procedural use. You know, it's interesting. Many years ago, Gilles Montelesco, I don't know if he's still here, but
Gilles is on the panel.
Oh, is he here? I can't see who's
on your panel.
I don't know if you remember this, Gilles, but when you visited many years ago Cleveland Clinic, you were telling me about a case you did, which was an unprotected left main through the radial approach with a 6 French guide. And at that point in the U.S., no one was doing a radial, and we were doing unprotected left mains, but, you know, 8 French sheath, balloon pump support. And it made me realize that even times where I thought support was needed, you know, oftentimes it ended up not being needed.
So as we discuss what we should do, she already crossed the lesion. Is this a CTO or not really?
Or maybe fake CTO. We call it now fake CTO.
There was a small channel
Alternative facts. No.
There was a small channel there. You could see that as long as it wasn't like bridging collaterals.
What was the wire you used?
No, this was just a regular fielder. And if, I think as mentioned by Dr. Lasala, you know, the proximal cap, the interesting thing here, yeah, we are in the distal vessel.
What wire was this, AK?
No, this was regular fielder.
Okay.
Fielder.
Yeah, the tip load for this is about 3.7.
And that's a fine cross?
Yeah, so now the same, if you would ask, if you go back here, when you're seeing the CTO,
there's a small channel.
So this is where you have a large diagonal, and then you have the proximal cap. You may think that it's a lot of calcium. So either you always try with your fielder wire, or even this is a good case where if you want to try fielder XT, or even you want to try your pilot 200, whatever wire that you think that you are comfortable with, this is a good case that you want to start with that wire. And if that does not go, then you go with the escalation where you want to go with your drilling wires if you have not made your way through. So
Anu, I am already getting greedy here. The way you pass through the LED, I think you could even consider doing the OMB after this.
Oh, OM? If Dr. Sharma gives us enough time.
So
now this is where we may have trouble if getting the fine cross.
Yeah, it looks like your fine cross may not go.
Yeah.
Yeah, this is where I do favor a microcatheter. It's got a little bit more body, and you can torque a bit. The fine cross is nice for tight
very interesting point, because not a bad choice. That remember we favor going with 6 French. Many people go with 8 French catheter so that they can go with this microcatheter or even a Corsair up front, so that when you face this kind of this is you see that calcified CTO, that if you think you have trouble, you already have Corsair in your hand to traverse that CTO. But we will show some other ways to do that. That now, if I think I cannot now, not a bad choice, that you can still rotate the fine cross, and same thing I'm trying to advance it. If it does not, then give me a 2.5 balloon. We'll anchor it, take it out, and go with a guide liner and a 2.0 balloon, which should, or 1.2 balloon. That's the smallest size balloon that.
You can use a Euphora balloon. We call them the pink balloon.
The threader balloon is.
The threader seems to be a good balloon that I've used a lot.
Yeah, threader has an interesting.
Just to go with the wires is the same. The first set of wires that you want, either your Miracle or the Gaia wires, because Gaia wires have now becoming a favorite of many of the CTO operators. It is a new wire family from the Asahi family, which has a composite core. They use the word what is called as a composite core, where they have, if you see that the core of the wire has what is called as a braided look. So what happens, your one-to-one torque is transmitted and usually deflects away from the lumen, tries to stay in the lumen, deflecting away from the wall. So this is what we call, you can do. So here I went with a 2.5 balloon. It's going to go up. So you anchor, the fine cross is out. We are anchoring the wire. So the fine cross will take out. You went up, right? How high? Up, well. So you can either go with the Miracle or the Gaia wires. If then that is done, then you go with the Confianza family. Down. That. Get me a 1.25 balloon. So the 1.25 is same. You can use a Sprinter Legend, or you have the 1.26 or 8 millimeter Trek balloons. Mini Treks, yeah. You have 6, you have 8. You can carry any one of them. Then of course we have Apex balloon also, which comes from 1.5. Once you have done this strapping, always make sure you pull back because there's a lot of air trapped in the guide.
Show us all the details of the trapping, please, here for our audience. You finished it already?
Yeah, done.
Yeah.
Can you give a guideliner?
But if you would not be able to pass any balloon and you have just the Y, would you consider to do rotational atherectomy here?
The only question here is I need the rotor wire across. The fine cross didn't even did not traverse any part of the CTO. Question would be, could it be a case for laser if nothing goes?
Yeah. Right.
If laser doesn't help either.
Yeah, native vessel, I'm a little concerned about laser because of the risk of perforation.
Yeah, well,
but it's something to think about, though, no?
The laser generally doesn't go through it, but it will fracture the proximal cap.
Proximal cap,
yeah.
That's true. It does
That's
help
the
you
point.
to penetrate with the balloon after that.
Okay.
And then she can go in with the balloon.
The other nice microcatheter is the Turnpike LP. I find that to be the most...
That's what I've mentioned several times already.
That's a good one.
And you could really torque it through.
So there are many options for transit catheter to
Yeah,
support
nowadays
that.
there are a lot. We have the Micro 14, which is from Roxwood, which is a combination, they say, is between Fine Cross as well as Corsair.
I wonder, why did you try with Fielder FC in a case like that? I mean,
Fielder, yes, the tip load is smaller. I think Fielder FC tip load is just about 1.9 or so, very soft. I think if I was going to go retrograde, I would have tried a Fielder FC. Okay, so I have the guideliner if I need be. Same thing, do not get the guideliner into the left main or any part of the proximal vessel until you really need it. You can leave it in the guide. So we are going with 1.25 balloon, which is a Sprinter Legend. Same, if you do, this is 1.26 millimeter balloon.
So the marker is in the middle, and that allow you to...
In the first 1 or 2 inflation, you'll never see the balloon. So let us see, same, not going, heavy calcium there.
It's so much calcium, I wonder if you are going to need rotational atherectomy or
well, eventually,
even orbital atherectomy.
If we follow the theme of this meeting, you need to at the end of it.
So now let me advance the guideliner into the guide, all the way there, proximal, and now try to...
So now here's where you're glad you have an Impella if you're going to use a guideliner, because the potential to get ischemic at any of the side branches and proximal LED has now just gone up.
What balloon is this?
Legend, I think.
14.
16, 18.
Legend or track.
It's the Legend balloon, Dr. Kinney?
Yeah, no, this is a Sprinter Legend. You see it open 1.25. So what I did, I think I entered a little bit, so you dilate it. Trying to go further down.
There's another risk with guideliner to cause dissection, so that's another good reason why.
It's a good reason to have that backup. It's a good reason to have some backup.
The other balloon I find useful here is the push, Apex push.
Apex push, yeah. We mentioned that.
That's what it's made for.
What size you have Apex push?
You're against the rock there, for sure.
Though that guideliner dissection risk is a little bit minimized if you always lead with a balloon and not ever lead with the guideliner itself.
But you see, she's really having a hard time passing that tiny little balloon across. You wonder what is going to be your next.
1.5 may not go. Okay, go up here. No, Apex doesn't come 1.25.
Time for the microcatheter.
Yeah.
20.
Okay, down. I think we all, I don't know.
I think a laser is
the
first way to go here.
But you need to warm up the machine now. It's another 20 minutes.
Okay, start warming up the machine.
Start warming up the machine. In the meantime, you'll have all these other...
One of the reasons I think laser makes sense here is because it's a very straight shot. You know, there's no tortuosity. You don't have to use the smallest size, I think, which is a 0.9.
Yeah, I agree. I mean, it's very safe to do this with a laser.
The only challenge would be that if there is any micro dissection, then you could virtually run into trouble. But
yeah, 0.9 is pretty safe, and you really don't need to cross the lesion. You just need to warm it up a little bit.
Okay, let's try some of the laser machine is coming. Okay, give me 1.26. We'll try 1.26 mini trek now.
Also, let us know if you want us to go to another room at all.
No, we want to see her cross.
No, we
all want to see the steps for this.
We want to see all your steps, but, you know, the laser takes a while to warm up, is what I'm saying.
No, meanwhile, we are trying the different balloons.
Okay.
So we are trying 1.26 trek, and after that, we will have the apex push, but apex push is 1.5. So if we are having trouble with 1.2, I don't know if 1.5 will go, but still we'll try it. We have 1.5. 12. You don't have shorter than that, right? Glider will not make it there. No.
I think you most likely will be able to cross it with the rotor wire. I mean, it seems to be.
After all this, she was did such a good job with the regular wire. I bet the rotor
and if not,
will go.
you can recross again with the fielder, but. Because sometimes that's if you really don't want to use the laser, that would be the best way to do it.
Okay.
But why not? Maybe the laser, this would be a great example to show the laser, because we haven't shown it. It would be great.
That's one of the few indications that remain in the coronary for laser. The other one was thrombus management. It's actually dissolving, vaporizing thrombus.
No. This. Oh, yeah. Okay. Good.
Well,
Which
sometimes
balloon was
for a
that? It
very
didn't do well at
underdeployed
all.
old stent.
Sorry,
although,
Deepak,
Ron, I would.
Oh, no, I was just saying another use for lasers, if you have an old underdeployed stent and you can't expand it, you can sort of use the laser to explode it open.
Yeah.
But that can be a little risky.
Contrast.
That's right.
Yes, with contrast.
Ron, going back to what you just mentioned about the use of laser for thrombus, I would qualify there more of a organized thrombus rather than fresh. Because the fresh thrombus, it'll just daughter through it.
Pressure.
Why? What happened to the pressure? Radial pressure.
So one of the talks today is on radial intervention. We have yet to see one, Dr. Kinney.
I think this is actually a very good demonstration that radial is not for all patients, because this is a very complex cases. This is not the bread and butter cases that are done in the lab.
And all of the cases in this lab,
so
and
none of these cases I would
today
say would fit radial.
Roxana, we do have contralateral access via radial.
All right, excellent. Good job.
Well, you did the radial for the Sentinel device, so that's counts.
Yeah, there you go. So tell us what you're doing, Dr. Kinney.
No, I think we are getting ready with the laser.
So did you try the apex push, or you just don't think it's going to be worth it?
No, I don't think it's going to do anything. No.
Yeah.
My experience that if the mini treks don't go apex, okay, give apex push while we are waiting for the thing to get heated up.
Well, anyway, we have to wait for the laser to be ready, right?
That's what I'm saying, but it's going to be a nice demonstration of laser.
What is happening with the pressure here?
Even after laser, you
Pay
only have to
attention to the
load
patient.
Just so calcified.
Why there is no pressure here? What was the ACT? Okay, can you? There's no pressure, guys.
Flora?
No, I took the guideliner out. Both radial, everything is no pressure there. Guys.
What?
Are you okay? Mr. Conte.
You can look fluoroscopy on the squeeze of the heart.
Is the impella in order?
The impella should give you a mean.
Wake him up.
We don't have good flow there.
Yeah.
Okay, he's awake.
Huh?
He's awake.
No, why you don't see? Guys, stop the laser. Just check why there's no pulse
Check the pressure.
And just check your coronary flow.
start CPR.
Yeah, maybe take that
we need to see
guideliner out.
No, I do not want to
Guideliner's
do
out.
anything. Guideliner is out for a long
Need to see a
time.
picture and see what's going on.
No, you cannot inject anything. First thing you have to rule out is any thrombus.
Now we're good. Okay.
Yeah, maybe bleed out the whole thing.
First thing, do not, in this situation, never inject forward. If there is any thrombus formation in the guide, I think there may be thrombus in the guide.
So you're bleeding it out now?
Yeah, but if that's the case, you probably like to take the whole guide out, to wash it, and to re-engage.
You're bleeding it out. What did you say ACT was?
And the blood pressure is okay?
386. Check another ACT, Rama.
Is there a cuff pressure at least that someone can obtain in the room?
The radial pressure should have been accurate, though.
Yeah, on the other side, your radial, contralateral radial.
Both are damped.
Oh, okay.
That's the thing.
You have three ways to measure.
And remember, this is a CTO case, so you always have to worry about perforation and tamponade, so all those needs to be, you can call echo to the room, you can
Patient's okay?
look fluoroscopy if there is any shadow of white.
Are you in the mean?
Can you show us the hemodynamics?
Show the hemodynamics down there.
Let's look at the impella.
And maybe just fluoro the cardiac silhouette.
No, it's moving.
There.
There you go.
What was that?
Just move the impella.
No, it's nothing to do with the impella. This is here.
Yeah, the heart is moving, so there is,
Now we got it back.
you want to make sure you don't have
Here
any
it comes.
tamponade there.
Okay. I mean, EKG, there was no change.
It is, though, that you see that the pressure tracing is not optimal. I agree.
I would call echo, just to make sure that there is no...
Okay, you have the laser ready?
Are you going to take a picture or no? Still.
See that?
Yeah.
I always try to figure this out before.
The impella again.
Yeah.
No, nothing to do with the impella. This is pressure tracing here.
I mean, the cardiac silhouette looks like it's moving very nicely. Can someone do a cuff pressure for you?
So it's a guy. It's something.
Where's the cuff pressure?
Patient is awake?
Patient is awake talking.
He's responding.
Okay.
Guys, you cannot figure out. I don't know, there's damped pressure consistently.
Yeah, I don't think you can do anything until you figure that out. Do you want us to go to Dr. Sharma or no? I know everybody wants to stay with you, believe me. But if you want us to go until you figure out what's going on, I'm open to that.
That groin's okay?
So the pressure tracing on the right coronary artery is okay? If you back that out a little bit?
Yeah.
Impella is working now?
Impella is
But
working.
vessels are open or what?
No, we didn't want to
There you go.
inject forward until we know that there is any. Now it's on and off pressure. Where's your cuff pressure?
Cuff pressure is still cycling from the last time. Still coming down.
These guys. No, why is this guy bleeding like crazy here? Huh? No, nothing to do with pressing. Okay.
We did the laser?
We may have to do the laser because
You want
nothing
or you
is
have
going.
done it?
No, we're going to do it now.
Okay, now you see that.
You want to show some pictures? and you
Coronary
want-
flow is good.
Then you
You
want
see
me-
that? Again, you lose the pressure as soon as we.
Let's check the right coronary flow.
No, right coronary is okay.
All your hookups are still tight?
Should we take a, while your laser getting ready, you want me to? We're not ready yet? Oh.
No, we are worried about this hemodynamics here. Forget.
Yeah.
I mean, it looks the same.
Good.
Right.
Laser is ready, we heard it.
We heard the laser, right? But I do agree, though, if you don't have good tracings, it's hard to move ahead with lasing
No, now it's okay.
without tracings.
No, that's the way. Then it damps, completely damps. I took the guide liner out thinking maybe thrombus, but nothing there. I give an ACT.
But the RCA is also the same. The radial.
The RCA looks the same.
No, the radial A line is.
The pressure tracing
Both
from
are
there.
getting damped. I think it's something wrong with the system here, I'll tell you.
So do we have a cuff pressure at this point?
Yeah, cuff pressure is 113 by 90.
Okay.
Oh, okay.
That's good.
So it may be the transducer got
There's
busted.
something with the transducer.
But both?
But why can you have both transducer trouble? Something
I think
there?
it's something with the. No, don't flush.
Dr. Kinney, do you want to figure that out and let us go to another room, or what do you want to do?
I think you should do laser first.
Okay.
If
We'll
after
look
laser
at it
you want
with
me to come
cuff
on the side?
pressures.
You want to get some echo team quickly meanwhile?
For what?
What they were talking about pericardial effusion?
No, nothing. They're just saying that you have to have. Okay, we have the laser ready to go now. Where's the thing? Give it to me. You have to have the flush, right? Who has a flush? You cannot have a dye, right? Only saline.
Only saline, and you're going to give 1 cc per second. Or you can just turn the flush on when they're. No, that's too much.
I'll do it.
1 cc per second.
Yeah.
Okay, no dye, only flush. Okay, guys, so this is our slow injection as I'm going forward with the laser. Okay, wait. Okay, I'm at the proximal cap there, right?
Yeah.
Okay, go. Slow injection.
We see it.
Go.
Yeah. Inject. I'm going with the laser. Are you ready? Yeah, 50-50. I don't see. I'm pressing.
Doesn't look like it's going anywhere.
Exactly. Okay, let's see. Ready again?
Yep.
All right.
Wow.
All right, Dr. Kinney.
Good.
You want to go a little slower than that, or no?
No, I know. We should be slower.
She can go fast if she's not lasing. That's okay.
No, she was lasing. I was hearing the
But
laze.
it's good. We see you smiling, so we smile.
How's that pressure tracing going?
No, pressure tracing is making me nervous. It's back to the same thing.
Good. Let's dilate.
Wake him up.
Anu, can we take one picture here to see
Yeah,
how?
we'll see.
Well, wait, let her bleed it back and all that.
Good things now.
Read that. You have a 1.5 balloon?
Yeah, but that area. Oh, that one. Yeah, we dilate both of them. Yeah.
Yeah, 1.5.
Just put a V.
Okay, 1.5 apex push.
Or maybe diagonal further down.
Okay,
Good.
let's see.
Okay. Yep. Now, which one is the wire?
Okay, I think we will just balloon this and put a stent across. Right,
Yeah.
guys?
Definitely. Looks good.
We can. You have a 2 ohm or a 2.5?
Let's just show us that a balloon is going to go, actually.
Okay, we will. We have
That's
now
all we
what,
wanna see,
what balloon
that-
you have?
And
The
redirect
laser
the
actually
wire
did
to the
something.
main.
So we have a 1.512 apex pusher.
I think a 2.5 balloon will go now.
No, we had
Your
2.515.
distal vessel looks cooked, you know?
Cooked?
Yeah, like, you know, I see some lines, maybe dissections.
Yeah, you're right. The laser. Okay, yeah, it's going. See that?
Wow.
Nice. Okay, open here.
That's just the small balloon, right?
Yeah.
Now you'll need a big long balloon, I think, like a 2.5 long, no?
In patients like that,
2530
if
balloon.
the end diastolic pressure is high, sometimes you don't see a good flow. So
Go up here.
Yeah, also when you have both
that's again another
injections.
advantage of having a right heart monitoring.
Go up here.
We just want to see you put a 2.5 balloon across there, and then maybe we'll go to
Now
Dr.
get us a
Sharma's
3.0
room.
now. 3.020 high pressure balloon.
Good.
NC.
Then you can, when we insert stenting, you can go across.
I'm thinking you need a 30 millimeter balloon.
Okay, flow is good.
You need a long stent here.
Long stent, yeah.
We take a 32, 38. Agree?
Start with 32.
Yeah. At least 30.
Roxana, with time, sometimes we forget, but one of my earliest papers was the use of laser for undilatable lesions in 1991.
Oh, wow. Yeah, well, here you go.
And
Here's
that was
one.
all the work done with
It's a really
Jim
good
Margolis.
example of how laser can help you.
Look, the real, I think, that was the comment which I had made earlier. If you had some tortuosity there, that was not the device. But this looked a pretty straight shot.
Yeah.
Wow.
Okay, now same, we don't need the right-sided catheter. Take it out.
18, 20.
The other important point, when you have contralateral injections, once you know you crossed it,
look at that.
You can take it out. Yeah, go.
That's really amazing how the laser just really opened up. I think it was the proximal cap. What do you think, Deepak?
Yeah, I think it was a great use of laser. Really useful.
Yeah. Dr.
Roxana, the other, if the laser would not have gone, I would have recommended her to slightly pull back the wire because it somewhat helps you advance.
Can't figure out what's wrong here. Go.
How's the hemodynamics? Good?
Talk to him. What did you sedate him with? Okay, go up here. That's good.
Good.
That's where I think there was disease there. See?
Yep.
Good. Down. Okay, now we decide about the stent length, and then you guys can move on to the other room.
I think has to be more than 30 millimeters, but take a picture.
Ready?
That was a 20 millimeter balloon, right?
That was a 20 millimeter balloon. I think we can take a 32
like a 33
stent,
or 32.
Yeah.
Wow, nice.
38.
38.
38.
Yeah.
And we are going to stent
What
across.
size you going?
3.5.
3.5, really?
This is a low mag.
That's a little bit aggressive.
That's aggressive, I think. 3.0.
You can always say it.
You could post dilate. It's a tapering
you can take the
long.
Okay, give us a 3.0.
Yeah.
I love
this is a
when
low
you listen to me.
magnification.
That was good advice. It's a 3.0 downstream.
What do you have there? 6 French?
This is a 6 French, low magnification. We are
3.0 is good enough, yeah.
3.0 will be good. You will. You are right
with
about
the long
proximal
stents,
vessel.
you can just
3.5.
taper them, and as long as you don't go high, you can still.
Okay.
But I think you can. You'll still go up with the post-dilate to on the proximal side. You're right. It's a 3.5.
It has a great blush and good distal flow.
Looks really good. How's the hemodynamics looking?
Good.
Why we don't believe you, Joe? You see, that's exactly the length you needed. Pretty long stent.
No, we are going to go across the diag, okay?
Yeah.
Because it started before the diag, right? Everybody agrees.
That's a good
now?
spot
Go up.
right there.
Go up.
So this was 32, right?
38.
38.
38.
Wow, that's long.
Good. Good. Down again. We did a fluoro save. I think the other thing that we all interventionalists have to be worried about is our radiation exposure. Down. Down.
That's down.
Okay.
I got to go up again.
Okay, go. Oh, wait, can you down?
And the strategy with the impeller would be to leave it for a few hours or to remove it immediately after the
We'll
procedure?
take it out here in the lab. if
She
everything
usually
looks
takes
good.
it right out there. Wow, that's nice.
Okay, we have some work to do. We'll recross the diag.
Get a run through.
No, fielder.
But you see the diagonal is there.
Yeah, but you can open that.
Yeah.
You'll
that
open
will
it
open,
right
we'll
now.
kiss balloon and we're good to go. You can go to the next room with Dr.
Yeah, and we'll come back. We want to
That's a
see what
pretty
you
good
do at the
collateral to
end,
that
okay, Dr.
diagonal.
Kinney?
No problem.
Yeah, show us. But you see,
Run
that's
through
why
and
it's
then
great. You have Impella. Is there ST changes or
Nothing. Rock
Okay.
solid. No EKG
Rock
changes, but
solid.
no blood pressure.
Okay. Okay, excellent. Let's go to the other room and we'll come back to you. Thank you, Dr. Kinney.
No, just at the end. Just like
Case number 10.
All right, we are
Dr.
ready
Sharma.
here.
Yes, case number 10.
No,
Okay.
Don't go out yet.
While the AK was struggling, we were trying to catch up on this particular case. So you have it, patient presented with dyspnea on minimal exertion, also has severe mitral regurgitation, has a stress test which shows moderate anterior ischemia, 86-year-old patient, severe MR, flail P2 and being evaluated for mitral clip, right? Has been made a non-surgical case, so they considered with that age, and of course the LV dysfunction, although LV is normal, but despite the normal LV, the surgeon felt that this is a good case for mitral clip. So clearly, remember, for the mitral clip, for the degenerative, you have to have their note saying that it's a prohibitive or extremely high risk. So this patient basically, from the angiogram point of view, and we are at a crossroad where we need your help. LV is good. This is the right coronary.
Can you put up? We don't see anything except case number 10 and your faces.
You're not showing it?
All right, now we see it.
Good. So basically, so far the right coronary is good. Mega, gigantic right coronary, not much disease. And then you go to the left side here, distal left main, about 70% angiographically. Circ has some bend, proximal, maybe 30-50% in the OM disease. But key is the LED diagonal bifurcation. And you can see here, you can see the ghost of the entire LED diagonal from mid to distal with the bifurcation at the second diagonal level, and then the LED.
You don't think that left main is severe, Dr. Sharma?
Well, no, but angiographically. This is the angiogram. Here.
Yeah,
what
well,
do you think?
It looks pretty severe to me.
Right?
I don't know. Maybe I'm not.
Agreed. No, I mean clearly now. Only thing is very eccentric. Here, you don't see the left main.
Right.
Because
Here
overlap,
you
but
don't see the
clearly
left
it's a
main.
very significant
So you got
left
both.
main, about 70 or you call 80, whatever you want to call, but calcific, moderate calcium.
Ectatic, really ectatic.
But real calcium, you see that there? But real calcium is at the diagonal, second diagonal bifurcation.
Yes.
And it's more calcium in the diagonal than in the LED. And I always say that for you to know, for calcium will be just take a cine of the vessels before you give any dye. And that is what we did. Actually, what try to do, same, knowing that people will ask whether it's a real calcium, severe calcium, and so again, this is the run-through wire into the second diagonal, and you can see here that the IVUS does not cross.
Right.
Now, even at that level, can we show that the circular frame? At that level, the first one, which was only circular frame,
it's 360 degrees, right?
Show the IVUS now. So that is why the IVUS did not cross with the back.
But we don't see the IVUS.
They're going to show it.
You're trying to show us? There it is. Okay.
So this
now
is the static image, and then of course we have the pullback. Can you show the pullback now? For rest of the LED and the left main. Now this is we started, and there's a lot of calcium. Anywhere from 90 to 270 degree, many times here, full circular calcium. And then we'll come to the left main area.
Yeah, let's see if that left main is very severe or not, because it's ectatic.
Which is the next one.
And you can measure the CSA.
Yeah.
No, we did the left main, because remember lengthwise, we have to go back again. Good. Show the last run now.
Second run, please.
The third run by definition. Yeah. So, lot of calcium, but good lumen in that area of the proximal LED. And now we are going to come back to the left main level. Yeah, this is it.
Right there.
Go back.
There it is.
Clearly very tight. What the lumen cross-sectional area came?
It doesn't look severely calcified there, though. The calcium is in the diag.
At that particular level. But remember, pre and post, there's more. What is the lumen here? 5.93. Good. So actually, if you play before that, remember the calcium point of view at the adjacent area. See, there is tremendous calcium, but not necessarily at that area where the tight. Actually, I felt it was a little ulcerated lesion. But you look at this, it's starting with the calcium, and then of course it becomes the tightest area here. It's a large plaque, positive remodeling, large vessel, and of course that is what we saw in angiogram. So clearly I'll tell you where we need the help here. So with that note, knowing that we could not, we did a rotablation using a 1.5 bar of the second diagonal, which is right here. And
wait a minute. Show us the angiogram. Now. We're seeing still the IVUS. Here we go.
Here. Yep. So this is here 1.5 bar. We were able to get a fine cross for the micro 14 actually further down. change it to rotawire, and then this is a 1.5 burr. You can see then the left main with the 2/0 burr, because 7 French guide we have, and then basically now we are dilated with the put the same marble wire, which is a stainless steel with the microglide coating, hydrophilic at the tip, and in the LED post dilated with the 2.5 20 high pressure, and this is the 3012 high pressure into the diagonal. So this is where we are now. So now the whole discussion here is what type of stent strategy for LED diagonal. I think the left main will be simple, because before the bifurcation, I'll put a 4/0, 8 millimeter or 12 and post dilate. The whole case is here that what stent strategy we should use in this particular case, knowing that we don't have a full anatomy of the ostium of the second diagonal. We know that the further down was very tight, which we have taken care with the rotablation and a balloon dilatation. We did a balloon of the LED minor dissection, and now I need help from the panel and yourself that what should be our 2 stent strategy. Should we put a V stenting? Should we do a culotte or do a mini crush? Various of the option, but I think in this case you need to bring before the just adjacent to the first diagonal. See, there is a eccentric lesion about 50-60%. So I don't think we should leave it alone. So whatever strategy anybody will advise us, has to involve that LED, mid LED after the first diagonal.
Yeah, so this is a very, very good question, because now after rotational atherectomy and ballooning, it's looking pretty good, that diagonal. And some people might say, just go across it and be happy, like a provisional. And be happy and just come out and don't, because the angulation of that diagonal to that LAD doesn't make it very, very good for T-stenting for sure.
And
or
believe me, Roxana, we actually talked about it, but the only problem is, whatever you do then, we know rota PTCA alone
is not going to be good.
Will have a high restenosis compared to stent.
Yeah.
So that's the
okay, so the good question. Who wants to go first?
Yeah.
Everybody.
We need a lot of help
Samir.
here.
Well, I think the size of the diagonal is large enough that I would go with the V stenting.
Okay.
V stenting?
Yep.
Who likes that idea? V stenting over here. John?
No, I think I would do a mini crush on this.
Mini crush.
Again, I favor the diagonal.
That's what I like.
I would put one stent in the ostium of the LED.
Gilles?
And then go from the mid LED into the diagonal.
Then
Gilles?
Third option, one stent only and a provisional stenting for the diagonal.
Okay. Wow. Okay. John Fox?
Yeah, I would tee it. It looks like an easy one to tee if you just do the whole LAD.
Tee it. What other alphabet do we have? Dr. Waxman, what should we do?
We need a mini crush up there.
He wants your help. He doesn't ever ask for help.
I'll go with one stent right now.
One stent.
A little bit provisional.
So we have 2 with 1 stent, 1 V, 1 T. Deepak.
All right. So now.
Wait 1 second. I just want to get everybody, Dr. Sharma.
Yeah, 2 Ts. I would favor the strategy of stenting the LAD, including that lesion right up to that diag immediately above, with provisional stenting of the diag, and accept the fact that there'll be, a higher rate of restenosis. But if the decision were to proceed, I think any of those strategies are fine. I tend to favor culatting.
And Tejas?
Yeah, provisional T for diag.
Provisional. A lot of provisionals here. So what are you going to do?
All right.
You don't have to listen to us. You just ask for help. You do what you want to do.
Samin, we've been absolutely no help to you.
Yeah. I thought, like you are my friend. You needed some help here. So anyway, so what we felt that key is that, as pointed out earlier, that the diagonal is a very big vessel.
Very big.
And proximal LED with the, mid LED. So we felt that to do, initially we felt a culotte. Because, or second is do a mini crush. So this stent we have.
This is the 3020.
So would you do the Triton stent here?
3020. No, I still think with this kind of knowing that there is a clearly no consensus, what I would have done otherwise, I'll put a 2 stent strategy here. And probably the best one, whether we change it to a mini crush, the John problem will be that you'll always miss a little bit of the ostium. So you have to bring it back into the main vessel with a little crush. You can call it a mini T, mini crush, microscopic, We have various terminology we use for those kind.
32528.
Yeah.
Yeah, the other side.
Long, 28.
Yeah. 3.5.
Yeah, 3.5. 3 or 3.25. 3.25. So this is a 3020, 28 Zions going into the LAD or not going into the LAD.
Attempting to go to the LAD.
Okay, looks like that you need to go to other side. The clapping is done.
Let's go to the impella side and come back to you after you really dilate this up well.
Yeah. You may have to do pre-dilate there a little bit more.
Yeah, of course.
Yeah.
Okay, Dr. Kinney. Can we see Dr. Kinney? Hello.
Do you see us?
Yeah, we see you. What's going on?
There we have our diag back.
I'm not loving that flow.
That's a good flow for that kind of
Let me see.
So this is where it was. See, we completely lost the diag in this view, right?
Yeah.
Nothing. You don't even see the ostium. So try to go cranial. You see that?
Yep.
But would not go with the fielder. Then took a whisper. You see, I have fluoro saved how we crossed it. So this is where we were deciding. Maybe we have to do the pot. Remember, since morning I've been telling how we have to get a pot. This is a case
then you
where
got
you think that if this wire would not have gone into the side branch, then we do a pot, make an proximal optimization, and then try to get into the side branch, and then we just did a kiss balloon. This is a kissing balloon.
Okay.
And this is where we are.
Oh, wonderful. Good.
Yeah. I think the side branch looks good.
What are you going to do now? Are you going to do a little bit more prolonged dilation in that side branch before you leave it? Because it doesn't look perfect yet. I'm not loving it.
That's the way usually the provisional, when you do a provisional stenting and you have a side branch, the ostium, that's the way it looks. I think once we take out the wire, we have 2 balloons, 2 wires in a 6 French guide. That's why the flow is not good.
I think you're done.
Huh?
You're done.
Yeah, we are done. So we take out everything. And,
you feel good?
look
Everyone
at the
feels good about this? We retrieve the diagonal. You would leave it, LIA, leave it alone, yes? Okay,
Yes.
Beautiful. How's the hemodynamics?
Okay, now you can show the hemodynamics. Now we finally found, because...
what was the problem?
Yeah, impella was at a full force at 3. What was your pump going at?
P9, now it's I went to P5, P4.
No, yeah.
You think the impella was in too far?
2.5, yeah.
Yeah, we were at P9, which was 2.5 cardiac output, and that's why his pressure was going lower and lower. Then we decreased, now we are at P5 with the cardiac output of P4.
Dr. Keeney, what was your LVDP to start with?
25.
Okay, so you may have actually, in the length of the case, driven it down quite a bit, and therefore you're spinning too fast.
That's probably what happened, yeah.
Okay, got that. All right, very good. Excellent. So you're done here.
We're done here.
Okay, we'll go back to Dr. Sharma. Thank you, Dr. Kinney. Okay.
And I think the 3.0 was a good choice. The 3.5 would have been enormous for that mid-LAD.
Yeah, that would have really closed that diagonal. Okay, Dr. Sharma, how you doing?
Well, we are trying to use the used balloon, and we cannot make a turn into the LAD, so we need to very angulate it. So now we are going to use a 2.5 new balloon and trying to open that LAD first. What else can we do? We did not do the rotablation of that LAD, and that is where it's creating a problem. The question was that should we have done that also? All the calcium is at this level.
It doesn't look like very much a lot of calcium.
Yeah.
That's interesting. You're still doing dilation.
Yep. It's still pre-dilatation because stents are not making turn. Go up.
You think if the stents don't make the turn, like a cutting balloon wouldn't either, right? So.
Yeah. So, well, we were thinking that should we use the cutting balloon now?
Yeah.
Or angiosculp at least. We had angiosculp.
Or something.
Well, that's sort of the poor man's way of determining if your stent's going to get there, right?
Yeah,
Use something with a
exactly.
high profile and see if it slides in easily.
Yeah. What do you have beside?
A new 306 and a used 3010. Used 3010.
Okay, let's see if this turn is made. See the very angulated turn of that LAD there.
Yeah. Very angulated.
20 negative. And at least the balloons are doing good so far. You know, one thing also you worry about in this calcium is balloon rupture. And I can tell you, anytime balloon rupture, it creates so much dissection. It's just difficult. So clearly, so far, all our Quantum Maverick and NCA packs and all those are doing very good. Now, still I feel it, resistance. Now, when I'm putting a balloon into the diagonal, nothing is happening. They're going very easy. Here we are still having a problem. Many times you go back and forth.
So it sounds like even a cutting balloon wouldn't go. Or maybe angiosculpt is a little bit better profile if you want to try. No? Like a 2.5 angiosculpt? Or no?
Yeah, no,
I think it's ready to take the stent now.
You think? I don't know. I mean, look, the balloon isn't going.
I'm still getting a lot of resistance here.
But this is a low-profile balloon now, and it's in...
Yeah. You want to try the stent now? We have the stent ready.
Yep.
I don't think it's going to go, but...
It will go.
Let's see.
Do you have any affection for the chocolate balloon?
Yeah. Sometimes we used to use it.
Negative.
The chocolate balloon is the other question here.
Yeah, actually, you know what? We used to use quite a bit of chocolate balloon, but we then felt that clearly that, you know, it's a good, if you are thinking about a standalone, the balloon alone strategy. And once you're really using for the debulking, it just did not give us that satisfactory result. So although we still have it, we can use it. We have the 2.5 chocolate. Okay.
Now, sometimes when you change
right
the
now we have
stent,
the Flextome. Right? What do you have?
Dr. Sharma, we have 12 minutes before we go to our talks.
Used one?
And you still have another case.
Okay. Yep.
So how are we doing this?
Okay, so it looks like that you are ready for your 3:15
Yeah,
lecture,
can
right?
we go to the other case?
No, the other case is not ready. I think best would be that you start your lectures, and this case will be playing on the side, and then we'll come after the lectures are done.
That's perfect. Thank you. Thank you so much, Dr.
All right,
Sharma.
we'll continue,
Wonderful.
but make
Thank
sure
you.
they
We're
show this
watching
case
you.
on the side.
We're watching you on the side. Thank
Yes.
you. Excellent. Go. Anu.
Yeah, so case number 11, WG, 53-year-old male who actually had a cath because of worsening angina class 3 at an outside hospital, diabetic hypertension smoker. So he was found to have a totally occluded LAD. He did have disease of the Ramus OM branch and RPDA disease. So essentially becomes diabetic 3-vessel. So I think at the outside hospital, they did have heart team discussion, but patient the same preferred, does not want surgery. They did the Ramus PCI, then were referred here for the PCI of, you can show the angiogram now, the PCI of totally occluded LAD, if you see here.
Show us the angio, yeah.
Yeah, so we have a dual injection, same. We have both, EF is near normal, 50%. And let me show you the dual injection. Yeah, if you can see here, this is where we are. So if you see the RPDA, significant disease of the PDA, 95%, very soft lesion there.
Yeah.
But angiogram they had sent us looked like was a very long LAD CTO, but looks, since now he has been on aspirin Plavix since he had PCI of the OM. Yeah, look, looks not like a 10 to 15 millimeter CTO, no longer, but more important is after the distal vessel, there's a large diagonal that is coming off.
I also see that your retrograde approach, if you need be, you have an option there.
Yes.
Of course, you have this lesion in that you know it's a type A lesion, but
that's another thing. I think if we decide if we can't go antegrade and you have to do retrograde here, that we have to probably stent the PDA first before even we do anything.
Exactly.
Yeah. But same like we had discussed, we will go with the Fielder fine cross into the LAD.
Okay.
And then we have our Miracle and the Gaia wire ready. Did you make a curve here? Give me the curve. Yeah. So we'll try with the Fielder first. If it does not, then we go with the...
So you're going to try the same way you did with the other CTO, which was so fast. The wire was easy. And this one is not going to be that easy either, right? There's some calcium there.
Yeah.
A little bit, not as bad as the other one,
yeah.
but let's
Not as bad as the other one, but definitely some calcium there. You have the Gaia ready? Or MB?
MB is ready.
Is it the same view?
That's not the same view.
No, this is not the, we moved.
Just go straight with a 6.
Yeah. Don't open if you need be. Go to this view, please. Yeah.
439. LAO 439 cranial.
Yeah, that's
The trick here is that there's the diagonal. This might just keep favoring to go into the diag, so it's going to be interesting.
Ready?
Let's see what you do. Any comments from the panelists? Carlo DeMario, while she's fiddling with the fielder. Is that a good approach? Antegrade first?
Yeah, of course, antegrade first. She probably saw a quite different situation before, but right now you have even the impression there is a little bit of staining at the level of the stump of the occlusion, so might be a sort of relatively acute lesion that was probably concomitant to the one that was treated on the left circumflex. Having said that, it's better never to underestimate, and of course the key issue here is to do properly with retrograde injection simultaneously while advancing the anterograde wire. I tend to prefer different type of microcatheters than the fine cross. Now you have big choice. You can go with Corsair Pro. You can go with thinner Caravel, which is particularly helpful also for retrograde approach. Turnpike LP again for retrograde approach. Regular Turnpike. You have again plenty of devices for various situations, and this made, I think, is one of the reasons why this morning Dr. Sharma could show its 90+% success rate, which is now commonplace not only in Japan but also in Europe and the US.
No, we are LAO 3 and 37.
Okay. Put it up. You need to put this up. That's what you need to do.
Okay, so tell us what's going on. So you, Dr. Carlo.
So I have the fielder. Let's see if it does not go. We are ready to change for a miracle wire.
Open 306.
It doesn't look as easy as the other one. You got through so fast on the other one.
Okay, get the miracle.
6, right?
Some die, yeah, some die, anti-grade, so we know we are
This is the amazing thing about these cores.
Miracle 6 guys.
Core, the first case is very complex, very difficult, and now you have a very simple.
And I think the question is the same. In the first 30 seconds, you know, you get, and 20 seconds, you get an idea that this wire is doing any progress. If there's no progress, quickly change. So we are now will go to the.
So your next wire is Miracle?
Yeah, Miracle.
Miracle 6.
Who is moving?
And the tip, you just basically just do the very tip and not much of anything.
So which Miracle?
Miracle 6 now we have.
Yeah, all right. So it's sort of intermediate, weight Miracle. I mean, majority of operators will probably go with these novel composite tips of the Gaia wires. Having said that, I mean, I'm sure that Dr. Kini will easily succeed, and I think that there are, you know, sometimes a little bit of fashion in the way people adopt new technologies. My impression is that the Gaia has very low tip load and gives a little bit more of security not to dissect and not to go into the extraluminal space. Having said that, you have seen in her capable lens, everything looks simple.
Here she goes.
What's important is not only to have the feeling of the wire moving freely into the distal vessel, but also have further confirmation with the retrograde injection.
The lesion. Looks like it, right?
Yeah, we crossed the lesion. You can confirm it with RCA. Injection?
Injection. Yep.
No, don't open the Gaia.
Yeah, you're definitely in the distal vessel. Hopefully this one will be easier to...
So now I think actually the fine cross has gone further down. So give me a 300 run through. So you'll go exchange it to a 300 wire.
300 run through.
So if the fine cross has gone through, what you can do is use a 2.5 balloon to pre-dilate this.
The 300?
Yeah, take this out.
Yep.
Would you do any kind of a cutting balloon or?
I think just regular balloon should be okay. If
You think so?
we use a NC balloon and we know it opens the lesion, then we are done. If not, we may use a atherectomy, either likely angiosculp.
Maybe before deciding the type of balloon, I mean, there is a fairly large diagonal immediately distal to the occlusion. So personally, I think we should go with a very gentle dilatation, not to be sure to close the diagonal and then wire the diagonal or use a dual lumen catheter.
So same, I'm going to take out the RCA catheter and bring it down and leave it in the descending aorta. You don't need it anymore.
Well, I like the idea of even trying to see, you know, to wire that diagonal. Maybe even now. Would you think about dilating it now? I mean, wiring the diagonal, or just
maybe
we dilate first.
Yeah, a 1.5 or a 2 balloon, I think, is relatively safe.
Balloon? What, 12? Okay, 15. So we have a 2.5-15 balloon. We'll do a dilation and we take a picture. Then we wire the diag. I think it's very crucial here. You need to wire the diag because there is disease in the diag. Yeah, get us a fielder.
Insufflator.
Deflector. Voila. Deflector. Voila.
Guys.
Looks like it's going.
Okay,
yeah?
right here, huh?
Yeah?
Okay, go up.
Going up here.
You might want to dilate a little more distally, too. Want to go more distal?
4, 6.
Okay,
there it is.
Okay.
8 atmospheres, 10.
Down. I'm going to go in a little bit. Okay, here. You don't want to go too distal and dilate the at the level. The diag is just coming off at that area.
8, 10 atmospheres.
Very good.
Down.
Dr.
Okay,
Mehta,
ready for
you'll
the
join
angiogram?
us, please, on the panel.
A little dissection.
Okay.
You
Looks
definitely
like
will need
needs a lot of vasodilator therapy to the distal vessel. Okay, we'll wire the diag now.
Okay.
Right?
How's the blood pressure? Everything else is good?
This is good. This is good.
So you can give a lot of
120.
vasodilation.
So even in your contralateral injection, you saw the LAD did not look robust. It was like diffusely diseased.
Yeah.
All the way to the apex. So we're going to give some verapamil, nitro, and then we'll start wiring the diag. Some
Here you go. Verapamil.
We have a blood pressure running about 120.
Okay.
So I gave verapamil half. Normally it's like 250 mics. So I'm giving a 200 mics of nitro, almost 150 of verapamil.
So with all these
nice
complex interventions, are you guys feeling comfortable putting these patients just on clopidogrel or an aspirin, or are you moving it up a notch with ticagrelor or prasugrel?
Where we are, if you are doing a bifurcation, all the left main cases today will be on Brilliant as long as we know that they can take it. Yeah. No
If they're not at a high bleeding risk, you are choosing a more potent agent,
Yes, definitely.
even though it's selective PCI.
Good. Another picture.
Let me just get rid of, hold on 1 second. Get rid of the water. Okay.
Hopefully you enroll some of these in the Twilight study.
More brisk flow. Clear the...
Okay, looks like a diagonal total occlusion rather than vessel straightforward. So but we will try the fielder first. Otherwise, we may have to go with the CTO wire even for the diag.
I think maybe a little bit more cranial, no? View that to help you with that.
You don't say, we are epicranial.
You are.
Cranial 40.
Some dye there. That's where it is.
Yep. There.
I think it's a little bit higher up.
Whisper.
Yeah, around there.
I don't know.
That's
See,
it.
I think that's where it is. It's behaving like a total occlusion.
Oh, really?
No, dissection.
I'm worried, is there a dissection?
Our predilation probably caused some dissection.
Or plaque shift into it.
Pablo, bring the monitor to me. A little bit this way. Yeah, this side. It's way away. Okay, there.
That's it. No? Oh.
No, no, no.
No, that's not it.
Maybe you can still see from the retrograde injection.
Diagonal.
Yeah, and before it was visible.
It was showing it before.
We took out the retrograde catheter. Okay, some antigrade.
I think it's a little higher.
I think we may need like a stiffer wire to get into here. Oh, now you see it better. Now you see it a little better. It's making it look like it's going, but you don't see it going there, some dye.
It's almost there. You got it.
There's a dissection right there, too.
Just look up north a little, and that's it.
Do you want to take a look?
So, yeah. Want to get the whisper wire?
Yeah. Whisper might help. So I think there's
Or some kind of a hydrophilic
Or even that
pilot.
the run through maybe going.
You want to bring the run through back?
Yeah.
No, she has the run through right there.
Tip of the run through.
Yeah.
We're trying to see if I can put the fielder
You're putting
here
this
in the,
and use the run through for the side.
Yeah. See that if that will work.
Yeah, but she can take the loop out.
Oh, this is a long run through. Forget it. It's loop.
And also loop.
And a loop. See, the tip is gone.
Want to try a whisper or need
Some dye.
Yep.
Okay, get us a whisper open. It definitely opened up better.
For this type of wiring of side branches, I must say I love dual lumen catheters. I mean, we have only the Crusader in Europe, but here in the US, you have now just released the twin pass torque.
No, we do have twin pass here, right? But was it here or it was called?
No, see, the Ventures was the one that were recalled.
Oh, recalled. Ventures were recalled. But we do have the twin pass catheters, yeah. We'll try with the whisper. You want to try the twin pass? But then how? Yeah, difficult. No, this is okay. Now we are trying with the whisper wire. Get me another run through. 180 run through.
180 run through. A new 180 run through.
I think it's a little down further. Yeah.
think it gets stuck in the lesion there.
Yeah.
That looks favorable.
I know.
Yeah.
Looks
Right
like
there,
that's
no.
where it is facing the diag, but would not go further in.
It's not a dissection.
You think you need a miracle, and with the
No, I guess like
With
we
the
do-
backup, just like you do a
no, we could
CTO?
do like a previous case. There's
Yeah.
a lot of dissection here, stent across, and then we retrieve the diag.
I just feel like you don't have support once you get in it. If you had the little catheter, the micro catheter, then you can change wires and do things that you need to do. It is a big diag.
It is, which we knew even from the. I think what's happened is there's a lot of dissection in the proximal area.
Yeah.
You want to go with the?
What about the steering catheter?
Oh no. Yeah, get us. No, that is not the one.
The supercross 90 now.
She wants the 180.
Do you want to go to another room with Dr. Sharma? Is he ready or no, or what's going on?
Go
Or
to room
should we
3
give
and
a
check
talk?
what are they doing.
Should we give a talk and watch you here?
Do a talk. We'll try to cross here and then you come back.
Okay, that sounds
That way
good.
is better.
Okay, excellent. So we see what you're doing. So we're going to go to Dr. Tejas Patel. He's going to talk
No,
to us.
Dr. Sharma.
Oh, you have something?
Room 3. Yeah.
What do you have?
Let's go for it.
Go ahead, show
Okay.
us.
All right, ready?
Yeah, we're ready.
Okay.
We've been waiting for this.
All the faculty is still there.
Yeah, you
Good.
lost some of them. They had to catch planes.
Yeah,
but-
okay, now clearly this is the case which we said. We did the diagonal, as you can see, balloon dilatation looked good. That's where we left you.
Right,
Now
and,
we
and
tried
then he
everything.
said do provisional.
Yep.
Then you couldn't
No,
get into
not
the
provisional,
LAD.
Nothing can go. Now we said, okay, let's try the chocolate balloon. The chocolate doesn't make the first turn.
Right.
Then we tried the angiosculp. Doesn't make the first turn. You say, okay, let's maybe flex tome. This nothing. Whether then we even changed to the Grand Slam wire. Nothing makes the turn.
So that means
It's small-
rotational atherectomy.
Well, that's it. So now this is the day.
There you go.
Another one. Now, as you saw, and this is what actually teaching point. Now you see here, there is a dissection of the mid LAD. Remember after that septal.
Yeah.
So the key is once you're doing a rota, don't go there. And this is purposefully, you can see here, what I've done is, I just crossed the rota after the bifurcation, that angle only.
That's
Not
it.
go to that dissected area, which is a type B dissection, although rarely you could go if the lesion doesn't open, but you want to avoid the dissection flap. So this is what we have done. We have, of course, you can see here, little better, dissection is still there. Now we still brought back our chocolate balloon because to make the Deepak happy. So finally it crossed. Only crossed after the rota.
Excellent.
But at least did.
The chocolate went.
Dilated, and then we had two stents now. 3.25 28 in the LAD to diagonal, and then 3.0 28 in the main LAD. So with the mini crush technique, we are dilated, we have stented the LAD, we just stented the diagonal, and we have, that's where we are.
Oh, beautiful. So now you'll cross
Now we
and
just
kiss.
have to do first, I think in this case, because of difficulty, this is again, will be doing a pot technique, pot for the proximal, that mid LAD before the crush, and then we'll rewire it.
Okay.
So I think this is the case. Now you want to go to the lecture. It's
Yeah,
perfectly
that's what
fine.
we'd like to do. This is great. We want to watch you.
And
We really want to watch Dr. Kinney. I'm sorry.
Yeah.
We want to go to Dr. Kinney because she's going to be on the side,
Okay.
and we're going to a lecture because this is just pot. And I know you do a great job, but we want to see
And you know
Dr.
that we
Kinney
still have to
cross
do the
that
left main.
diagonal.
We still have to do the left main in the heart.
I know. But we'll come back. Don't worry. Don't
Okay,
feel
in
bad.
him.
We will come
him.
back to you.
Yeah.
I promise.
you.
Thank you.
You want to watch DK
Join
crush
us here
versus-
because
Sharma
you
is
know
done
that we got to
in the
go
other
to
room?
Dr. Kinney. God, oh, there she goes. She's got that diagonal open. Please, we need your, but what we just saw, a lot of you would have liked it, Dr. Kinney, a lot of complications with radial. But how to deal with them from Dr. Patel. Excellent, excellent talk. Go on and tell us what you did and how you got into that diag.
So one of, you see that we had created a lot of dissection in the LAD, and that probably was preventing my wires, which is fielder, and we tried whisper, getting into the diagonal. So one of the suggestion given, you see that he said use twin pass was not a bad choice, but instead we did something else. We knew that we are in the dissection plane and we are not going in, so we used this remember we had the fine cross.
Yeah.
I went back with the fine cross and then took a miracle 3 because
that's what I was
regular
saying
fielder
to you.
was not going. So just with the, you can see this is a fluoro save. With the miracle 3, with the fine cross there, we were able to get into the diag. We dilated it, and this is where we are. It's a large diag, large LAD, and what is the stenting technique you want us to show?
Well, I mean, I think, you know, there's no question now you have to do a dual stent.
Yeah.
And it looks to me like another mini crush because, and I don't know, we have a panel here. Carlo, so she went back, she got this. Carlo and Gilles, either one of you. Gilles, first, then Carlo. What do you want to do here? There's no provisional here, Gilles.
We have a 6 French guide.
Yeah, I agree. Mini crush technique would be possible. I'm a little worried by the dissection upstream. We need to cover it well. It could go higher, of course.
Yeah.
So we need to be careful with the left main.
Right. You see the dissection coming all the way up. I mean, your LAD stent is going to be quite long. So I think you're right there. Carlo? Any additional remarks?
No, I fully agree. I think the crushing for that particular case is an excellent technique. I tend to use more often double kissing crush, but here I'm also afraid a bit of leaving the dissection too long and moving backwards into the main.
Yeah, this way we avoid having 2 stents at the same time.
I mean, I think you're going to need a pretty long stent, and not maybe even a little longer than that. No? Dr. Kinney,
No,
in the LAD?
this is not the stent. We have 6 French. I cannot go with 2 stent.
Oh, okay.
Because it will be 3 or so. We'll have to do either a DK crush or a serial T stenting.
Okay.
So I have a balloon in the LAD. We have a stent in the diag. So we will stent the diag.
And then remove it.
Okay.
Yeah. So show me some dye. Who has the dye?
I got it.
Okay.
There you go.
Some dye. Yeah. I think we are covering the ostium. Agree, everybody?
I think you have to come back a little more.
No, here. See that.
Let's see.
Good.
Now better. Good.
Okay, go up.
Going up on the stent?
Yeah.
Yes. 6, 8, 10.
Go. 14, 16. Right?
Correct.
Down. Go up again. So now if we are going to use a DK crush technique, I have to take out the balloon, the wire, and then with the LED, I have to crush the stent.
Yeah.
Yeah, with the LED balloon. So looks good. This coming out, wire coming out. This is a fielder, right? Fielder has to come out.
Correct.
Good.
I'm ready to crush whenever you tell me.
Yeah. Now we have to crush that stent. Good.
Ready?
Go.
Going up.
What size is this balloon?
This is a
You have to be
3/0
careful you
balloon
don't
that we
dissect
had.
upward.
10, 12 atmospheres.
You know,
Good.
you haven't sealed the dissection proximally.
No, don't worry about that. We'll stent later. First, let's take care of this side branch. See now, when we crushed, I think the ostium of the stent got a little
looks
collapsed.
small.
Okay, get us a new fielder, I guess. Right?
Yes.
This is gone. Okay, done. Coming out.
Okay.
Good.
So the idea is now you're going to go back and recross that.
Yeah. See that crush? You see that?
Yeah, we can see the bunched up, crushed stent in the ostium. So let's see if you could cross it.
Exactly. And then get me a new fielder. Let's cross. And get me, actually once you recross, your balloon that you need to dilate has to be an NC balloon. But we always have
like
trouble.
to use in
So we
CTOs.
probably-
I like to use a larger. I like to use a 7 French guide always.
Yeah,
you know,
yeah,
with CTOs.
exactly. We would have been done with mini crush and going home.
You go home now. Yeah.
Yeah. Now you have multiple steps here.
Okay, but that's good. It's a good example that you teach us.
And get me a 2012 balloon, right? 2012. So we cross, open it. Oh, only problem will be the same. This dissection may prevent us from crossing in the diagonal.
You got it.
You think a 2-0 will go?
I think it will. 2-0 will go.
Get us a
1.5 is nicer,
1.25
but
ready. You have to do a kissing also, right?
Yep.
We have to still deploy the main vessel.
You got to follow the steps. It's on your app, isn't it?
I know.
In case
I
we
would now
forget.
want to do the DK crush.
Okay.
But it avoided the issue of two.
So tell us the steps. Go through them all. So now you will
Okay, now
dilate
I
that.
need LED balloon.
LED balloon or LED?
Good. So good.
See how nice it went?
And this
And
will
now
be
you'll
this will
kiss?
be the first kiss.
Let's bring the other balloon
You have the
too.
3020, the same balloon.
2.0? Why not 2.5?
Okay, yeah. Give me. You have the 2.5, right? Yeah, get us a 2.5 to the LED. Agree. What's the stent you want in the LED? We'll take a long stent like you guys
You
mentioned.
need very long, I
You
think.
want a
Well,
38?
guys, what do you think?
No, we'll take a caudal picture to see how proximal.
I think you need to take a little better picture for me to see where that. I don't think this is a good view. I think maybe an iliocaudal something to show us where it, or an ariocaudal something to see where that proximal dissection is coming into to the left main. Some other caudal view.
Okay, good. We are going with the LED balloon. So we'll dilate the side branch. Then we do the kissing. Then we get the LED stent in. Then we have to recross and kiss again. Okay, good.
Yeah.
Okay, I'm going to the diag. Going up. Go. Go.
And going up.
Still doesn't look very
We want to make
nicely
sure that the
dilated,
ostium
you
is
know.
nicely open.
What size is that? 2.5?
Yeah, we went with a 2.5. You told us go 2.5. We took 2.5.
Yeah. What size
I mean,
is in the?
ideally should be 1-to-1 in the LED. Should have been a 3.0. And then the diag we have a 2.0, but it should be 2.5 NC.
2.5 for sure. I just
Good.
don't like
Yes,
that
yes, good.
at all.
Done. Okay, slipped. He wants to go there. You want to go there or you want to watch the steps? Now see that we have nicely opened the diag, that crush that we did. Ready?
Yeah.
I'm ready.
So what did the DK crush study definitely showed that if you do this crush and then kiss, and kiss, that you're recrossing after you place the first, stent of the main vessel, recrossing and as well as kissing is higher rate.
I just want to see the extent of that dissection
We will.
proximally.
I'll give you a caudal picture.
Is it, hopefully it's not in the left main.
Want to stent?
Not to worry. Now we stent.
3.0.
38 or 32?
32.
Here.
We'll see.
Okay, caudal.
Here we are, caudal.
It's too big, no?
You need to get those wires more distally.
Ready?
I'm ready.
The diag wire.
Diag wire is a little backward. That's
Yeah.
okay. It has to come out anyway.
I know, but.
Looks okay,
Oh,
no?
okay, good.
Yeah.
So
we
you
will
see,
put
I
a
just wanted to
3.0
make sure
we'll
you
put
see
a-
how much
yeah.
better you see that.
We'll put a 3.038, then we recross and kiss.
So, okay, Dr. Sharma
Dr.
wants
Sharma
us to go to
wants
him.
you, but
Can we go to him?
Yes.
And then we need to also finish these talks. Dr.
Okay.
Sharma. Oh, good.
Okay, we are all ready.
Okay.
That's where we left you.
No.
All right? So far,
Excellent.
everybody. I know I'm
Yes.
saying no more fatigue, 1 more hour. delay the fatigue for 1 more hour.
Okay, no, don't worry. Nobody's fatigued.
All
I'm not
right,
fatigued. I was saying goodbye to Dr. Patel.
Okay.
I'm not fatigued.
Yeah.
Keep going.
Good, I like it. Okay, now this is where we left it. So we did the pot proximally. Then we use a 2O balloon, crossed. And then you can see here, we are doing a multiple kissing balloon dilatation. This is while we are injecting, beautiful result.
Very nice result.
Calcific. What we learned here is basically, I think it fooled it. Fooled in the sense that angiographically more calcium in the diagonal we did rota. So how could I have made that mistake? The rota guru. Why did I not think about the rota before? I will tell you what happened. After doing the rota of the diagonal, we say, okay, let's put a balloon wire in the LAD. And balloon went without any resistance. So that's kind of a false, but clearly we paid the price, took extra time. But anyway, this came out good. Then we went to a 4.0 flex tome of the distal left main. And this is a 4.018. Zions post-dilated with a 5.0 at few areas. And you can see here, so finally this case has been fully revascularized and ready for the mitral clip in next 1 month.
Excellent. Thank you. Unbelievable
All
case.
right.
Beautiful
Now
case. Thank you. Wow. Incredible. Incredible. So can we just see Dr. Kinney, but I don't know if she's still working. All right.
We are doing good.
Because we need to go to the talks, okay? Because we're way behind here.
Okay, what do you want to do?
I'd like to go to the talks, if you don't mind, because
no problem.
We'll put you on the side. Just put this stent.
You see that? We are now with the stent. We are coming, like you mentioned, we went to the caudal. We wanted to make sure we are not, it's good, right? That's good.
Yeah,
looks
good.
To the ostium.
Just make sure you don't go too much into the left main.
No, will not.
Okay.
No worries. See that septal? We can pull back a little bit.
So if you just deploy that stent, we need to go to Samir Mehta, who's going to talk to us about global STEMI process. Otherwise, we're never going to get done. We still have a bunch of more cases.
Where's the mic? Thank you. Mike is here. Thank you, Samira. Let's go to the cath labs to Dr. Kinney for a brief follow-up.
So, George, this was a case of CTO of the Prox LAD. If you see there, and after we opened the CTO, we found that the diag had a significant disease. So you saw that since it was 6 French, we had to use a decay crush technique. We left off here where we recrossed. And we did the first kiss. This was the first kiss. And then what we did was we took a 32 stent into the LAD. When we went to caudal, we saw that there was osteal disease. So we came back, covered the ostium of the LAD. And this is how it looked.
Looked very good.
Yeah. So now after that, we did another kissing. This is the final result.
So it seems like this is a complex bifurcation as well as a CTO.
Exactly. Complex bifurcation, so we showed the technique of decay crush, and this is the final result here. And I think earlier the question was the same, that this kind of complex disease bifurcation long stent will definitely get brilliant, and he'll be part of the Twilight study.
I think sounds like it should be. That's a great result. Congratulations, that's a great result.
Thank you.
All right, should we get ready to proceed with one more talk here? Before
go with one more talk, and then we come back here, right?
Okay, very good.